I'd like to thank the organizers, Bert and Tom and the others, for including me again in this fantastic meeting, which this year really moves to an area which is very close to my heart. The idea that all the things we discuss are designed to reduce lifetime risk for our patients, the population, and ourselves from cardiovascular disease. And while we silo them into topics, the issue is really the same. Diabetes, lipids, blood pressure, and the like, all contributing to those cardiovascular risks. So I think in the population, at least in the UK, we've reached an inflection point in terms of aging. Peter Libby opened the meeting yesterday by challenging us and asking us whether we were interested in the aging process. And of course, every one of us is or should be interested in that. And in the UK, some interesting data about 6 months ago were published to show for the first time the population's life expectancy has stopped increasing and may actually be crossing that line and actually be reducing. We're used to thinking that the next generation of our population will have a longer life expectancy than us, and this may not be occurring. You can see here how we're now, for both men and women, crossing that point in time when the next generation may actually have a shorter life expectancy. Now, the real driver for that, I'm going to argue to you, is the type of behavior and risk factor profile that is driving the epidemic of diabetes and its complications in the population. Because while all of us remain at high risk of cardiovascular disease, if you get diabetes, the situation is very much worse. We know that for both men and women, diabetes increases greatly your risk of a cardiovascular problem. Notice that it affects women and men very equivalently. Notice also that the impact is on young people, the loss of life years, so that it is the 40, 50, and 60-year-olds who are losing proportionally more life years from their diabetes. And it's a sobering statistic that for a 50-year-old with diabetes, even in the absence of a history of vascular disease, they're going to die about 6 years younger than the equivalent individual in the population who has no diabetes. A huge impact. Now let's look at how we've managed this problem in our medical systems over the last 30 or so years. These are interesting data published in the New England Journal of Medicine, looking at the benefits that we've obtained by managing glucose and its related complications, compared to the impact on cardiovascular disease. Now, our diabetes colleagues have done a spectacular job in reducing the impact in terms of mortality on managing blood glucose better. These are really dramatic declines over 30 years. But in contrast, we've done rather less well at reducing cardiovascular-related problems. We have done reasonably well reducing, at all ages, admissions to hospital with cardiovascular disease, but this still remains a huge problem in terms of the impact on the medical system. So increasingly, the goals for the management of diabetes have to be reducing and delaying cardiovascular complications in the patients with diabetes, both with and without clinical evidence of cardiovascular disease. Now, today we've been discussing a whole range of risk factors, inflammatory states, and the like that come together that drive the atherosclerotic process and increase the risk of its complications. And in diabetes, and in particular, during that prodrome, that many years that we're going to talk about, in which we are putting ourselves at risk of developing diabetes, all of these things come together to create an inflammatory environment, a situation where glucose regulation goes wrong, lipids become altered, blood pressure is altered, coagulation changes, inflammation builds up, and all of these drive the potential risk of future atherosclerotic vascular disease. And the recent Swedish registry data highlighted this challenge to us of managing those modifiable risk factors that might actually make an impact on morbidity and mortality. You can see here in the Swedish registry, more than 250,000 patients with type 2 diabetes, matched to nearly 1.5 million controls, median follow-up 5 years, demonstrating the impact on death, myocardial infarction, stroke, and heart failure, and showing how lipids, glucose control, and blood pressure all have a variable impact on these different manifestations of cardiovascular disease, and therefore become reasonable targets for our intervention. Let's look at what we've achieved then with conventional therapy in managing that cardiovascular risk. These are data put together 10 years ago by Koch-Ray and colleagues, who looked at all the different trials for blood pressure, for cholesterol lowering and blood sugar lowering on the impact on cardiovascular events in type 2 diabetes. Now, we've concentrated as a cardiovascular community on lowering and managing blood pressure and lipids, and actually we were right to do that, because with traditional medications, this is where you get the best bang for your buck in reducing cardiovascular events in patients with diabetes. Notice that the impact with traditional medications on glycemic control was rather disappointing in terms of macrovascular complications. Actually, it was even worse than that, because trials began to emerge that if we pushed that aspect of our treatment harder, we might actually not only be failing to do good, but actually be doing harm to some of our patients in different situations. Steve Nissen put the cat among the pigeons 10 years ago when he reported that rosiglitazone might actually increase the risk of myocardial infarction and death from cardiovascular diseases. And that really spooked the journals here, the BMJ. A perfect storm was reported in the front cover, and that spooked the regulators into demanding very stringent criteria for licensing of drugs to lower blood sugar. So we were in a really down period of treatment of these sort of patients, when we felt that we had not much to offer in terms of cardiovascular complications from better management of their blood sugar. And then along came a trial, which we've been talking about over lunchtime and which every one of you will be aware of, which has really changed the game in terms of the way in which we might approach the management of patients with diabetes and cardiovascular risk. Not only is it an interesting trial in and of itself, but it forces us to work in a different way in clinical practice and to ask questions about the real nature of the pathophysiology of heart disease in patients with diabetes. This was the EMPA-REG trial that appeared in the New England Journal of Medicine in 2015. You've all seen the data. Quite astonishingly and very surprisingly, we didn't just see a lack of inferiority, we actually saw superiority into this trial. But what it really showed was a dramatic and very rapid improvement in the manifestations of heart failure and all-cause death, occurring within weeks of initiating medication. And this really forced us to think about the way in which this agent might be acting in terms of producing that cardiovascular benefit, something that I'm sure will be discussed in the rest of this session. About the same time, another class of drugs which have been introduced as a glucose-lowering class, the GLP-1 receptor agonists, also reported cardiovascular benefit for the first time. There were 2 trials back-to-back in quick succession, liraglutide and semaglutide, the leader, and sustained 6 trials, which again showed statistically significant cardiovascular benefit, but with a very different pattern of benefit emerging, with a much longer time course to see the separation of those curves, suggesting potentially different mechanisms. So now, from a nihilistic position when we had not much to do in terms of these classes of drugs, we now have 2 classes of drugs with evidence-based for improvement in cardiovascular outcomes. And this is really quite exciting. We have the SGLT2s, which are probably acting largely by a hemodynamic effect. We can discuss this in terms of producing cardiovascular benefit. The GLP-1 receptor agonists act, it appears, on the blood vessel wall potentially. And by lowering those 2 impacts on cardiovascular disease, we might have the opportunity to really make a difference on macrovascular complications in our patients. It certainly changed the way in which we're thinking about the clinical manifestations of diabetes. The EMPA-REG trial and the improvement in mortality, even in patients who were not those known to have overt heart failure, really opened the door to the idea that the mechanisms that are pro-atherosclerotic might actually be pro-inflammatory and damaging in different ways to the myocardium as well, and that we've probably underestimated the potential importance of the myocardium and heart failure in patients with diabetes. If we look at some of the large national registries, these are the UK data that we curate in our department. For all admissions to hospital in the UK with heart failure, more than 1/3 of the patients had diabetes. This association is extremely common and may be very important. So at the very least, what's changed now is that we as a cardiology community have to engage with the management of our patients with diabetes and work much more closely with our diabetologists. We need to update ourselves on good diabetes care, understand these drugs, understand their problems. We need to make sure that diabetes checks have been done in our patients. It's not a lot of work. We need to get together with our local primary care doctor and diabetologist to start to see what we can do to manage patients better together. And don't forget to screen for diabetes in your patients. Rather facetiously, I've written here, it's not that complicated. Surprise your patient and ask them about their diabetes. Now, these two classes of drugs have raised a number of really important questions that are now being addressed in ongoing cardiovascular trials. We need to really begin to understand how these drugs produced those surprising benefits in cardiovascular mortality. I call this a strange situation when we're moving from bedside back to bench rather than the other way around. There are probably patients who will benefit more from one or other class of drugs, and this is the beginning of precision medicine potentially in the patients with diabetes, patients with heart failure or kidney disease doing better than other patients with one or other of the drugs. And most importantly, this has really opened up the idea that these aren't glucose-lowering drugs at all. These are cardiovascular drugs producing different potential benefits on the myocardium and the vasculature, and that they may be beneficial even in patients without diabetes, or certainly in patients without cardiovascular disease. And understanding all of those questions will become much clearer as a result of ongoing clinical trials. So as clinicians today, how are we going to use these agents? Well, we have these two agents with clinical benefit. Should we be using them together in our patients with diabetes to reduce their cardiovascular risk? We've seen that they have complementary actions, so potentially they may benefit together. There are one or two studies that show that they act synergistically on HbA1c and glucose control, but there are, at this moment, no cardiovascular outcome trials comparing the combination of these agents against single agents alone, and those trials may actually never happen. Are there specific patient populations for one or other drug? Almost certainly there are. Quite clearly, the patients with heart failure will benefit more from an SGLT2 inhibitor, whereas the patients in whom you're modifying atherosclerosis risk associated with obesity, for example, you might choose to start with a GLP-1 receptor agonist. We're going to have a talk this session about the way in which guidelines are adopting these agents, and this has moved rapidly into clinical recommendations. And we'll be in the era when price becomes an issue in terms of prescribing behavior and recommendations in view of the very large number of patients who might benefit from these agents. So what we've been talking about so far is treating patients who have established diabetes to reduce their cardiovascular risk. But as a thought that actually underpins many of the discussions we've had today, why would you strive to treat a disease like diabetes better when you might actually be doing something earlier on in its evolution and actually prevent it? We all know that the diabetes epidemic is probably the existential risk to world health that's emerging in the next 20 years. By 2035 to 2040, about 1 in 10 people in the world's population will have diabetes. We're never going to be able to prevent that by better treatment of patients with the disease. And the drivers of that epidemic of diabetes, we know, are adiposity and behavioral change in the population. And that starts remarkably early. In the paper on the right, you see here the pattern of overweight in young people, in teenagers and young people. And you can see the hazard ratio for the development of diabetes already emerges dramatically in the first 15 years of life. Now, what we're doing is creating a generation who, if you like, are doomed to suffer from the diseases that are going to cause cardiovascular morbidity and mortality. These were astonishing statistics that were reported in the New England Journal of Medicine a couple of years ago, looking at the obese generation of 0 to 2-year-olds in the United States and the chance they have of remaining obese at the age of 35. For a child who's obese at the age of 2 has a nearly 90% chance of being obese at the age of 35. Very few of these children who are obese in the first 10 years of life lose weight, and get into a normal weight cohort. This is a potential disaster for the next generation of the population. Now, what's going to happen to these people? This is a paper which looked at the outcome of patients who were obese in adolescence and determined their cardiovascular outcome. And you can see here a BMI during adolescence tightly linked to premature morbidity and mortality, and almost entirely that cardiovascular morbidity and mortality was related to the development of type 2 diabetes and hypertension. So instead of just waiting to treat our patients with diabetes, we really as a community have to start to think about the early life of the next generation of our patients. Our patients are starting these days with a very poor start in terms of their future cardiovascular risk in childhood, and they're going to carry that risk forward to adult life with a huge burden on the medical system. Now, this idea that diabetes isn't a separate disease that confers cardiovascular risk, but is actually the end game of a situation in which we've had for many years an increased cardiovascular risk, was very nicely shown by long-term studies that were published years ago. Many of you will remember the Nurses' Health Study looking at the emergence of cardiovascular events, myocardial infarction and stroke, in a huge population of more than 100,000 nurses, and looking at the relationship of those events to the development of diabetes. Not surprisingly, in that follow-up period, the nurses who did not develop diabetes at any stage in the study did well. Those who were diabetic at baseline had the expected increase in cardiovascular events. But the nurses who got diabetes during the study had an increased cardiovascular event, and many of those events presented before the clinical diagnosis of diabetes. So this is a continuum of risk that is developing in the pre-diabetic stage, which predisposes to the clinical events we would like to prevent. It's exactly the same as when we look in secondary prevention. The state of dysglycemia or abnormal glucose control confers a substantial risk even in people who have not yet had the diagnosis of diabetes. These are the data that Lars Rydén and colleagues collected in Sweden, looking at patients coming to the cardiology community with an acute coronary syndrome in the coronary care unit. And they were amazed to find that around a third of the patients who came to them had diabetes, a third of them had impaired glucose tolerance, determined objectively, and a third of them had normal glucose control. Subsequently, this cohort has been followed to look at the cardiovascular outcome, and you can see that the patients with the normal glucose tolerance did well, but the patients with diabetes, and importantly, the patients with just impaired glucose tolerance, did much worse than those with normal glucose control, with no difference at all related to the diagnosis of frank diabetes. So we have a challenge not just to manage the clinical stage better, we have a challenge to operate on the pathway to diabetes and start to intervene before the clinical events develop. And that challenge is encouraged by the recent data, again from Sweden, which looked at the potential benefits we might see by controlling risk factors from an early stage in a diabetic or pre-diabetic population. You can see here in that large Swedish cohort that if you were able to control all of the risk factors, you could completely reduce the risk to background to baseline associated with from acute myocardial infarction and cardiovascular disease. This is a potentially preventable problem by addressing the long-term impact of these risk factors on the patients. So this fits very nicely with a changing philosophy for disease management. We've got to get away from short-term 10-year risk and those sort of metrics in our guidelines and in our calculators. It's lifetime exposure to cardiovascular risk that leads to the clinical disease. And that remains true even in patients with diabetes. The key is going to be sustaining broad, even modest lowering of risk factors from an early stage to leverage those cardiovascular gains. When we talk to patients, we say it's never too late to do something. Actually, what we should be saying to our patients, it's never too early. Now, I just wanted to put this in because this fits in with Peter Libby's talks both yesterday and today, looking at the broad pattern of risk profile and the development of a whole range of non-communicable diseases, which may share common mechanisms and may share common risk factors. And it may well be that by managing obesity, stress, and cardiovascular risk factors early, we don't get a gain from that individual disease like diabetes or cholesterol-related diseases, but we gain leverage gain on a whole range of different diseases like cancer, diabetes, stroke, dementia, and atrial fibrillation. And it's probably the common biological pathways that underpin inflammation, oxidative stress, that are driving unhealthy aging that lead to those diseases. Now, it's interesting to speculate that if we were to move upstream with our treatment targets and manage those biological pathways, we might benefit not one of those diseases, but several of them. So this was a study we just published last year looking at systemic inflammation as an exemplar of how reducing systemic inflammation from a common situation like gum disease might produce multiple gains in terms of cardiovascular risk. We took a bunch of people who had gum disease in the UK, which is very common, and almost a third of the population have it, and we randomized them to treatment of their gum disease without drugs that was effective or standard, which changed their gum disease over a one-year period. Look what happened to the individuals in whom we were able to restore healthy gums over that 1 year. HbA1c fell by almost 1%, about the same difference you see with those GLP-1 receptor agonist trials. Look what happened to glucose. This is flow-mediated dilatation, endothelial function in the systemic circulation. And this, provocatively, is creatinine levels and kidney function. Within a year of removing systemic inflammation, we can produce quite a substantial benefit in a whole range of clinical manifestations. Now, this is with an intervention that takes away a common source of inflammation, but it may be possible with dietary manipulation and lifestyle change to do something very similar. We talked rather simplistically, I think, this morning about low-fat and high-fat diets. There may be other features of the diet which could have a real impact on those early biological processes. This comes from Longo and colleagues in the cancer literature, looking at the impact of intermittent fasting or fasting-like diets, not only on cardiovascular risk factors and weight, but also on cellular regenerative processes and other markers of cardiovascular and other health. What Longo and colleagues did was to show that just a 3-day near-fasting period done once a month changed completely some of these important pathways in experiments, in animal models, and now more recently in the human, suggesting that you could alter those biological pathways that underlie many diseases by those simple lifestyle interventions. Here is some recent data published from that group. This is the fasting mimicking diet and markers of aging, type 2 diabetes, cancer, and cardiovascular disease, all beneficially changed. So this is a way that might actually allow us, by simple lifestyle changes, to alter our trajectory, not just to one or other disease like diabetes, but a whole range of things we'd like to avoid. Now, there's a real opportunity to take some of the new drugs we have and test them not just in patients with diabetes, but start to test their different interventions and their different effects on that long preclinical phase of disease, and try to separate out what it is that might actually benefit the patients over and above the impact of lifestyle changes. Weight is clearly an issue. Obesity is clearly a driver of some of this. And up to now, we've had very little that we can do pharmacologically to reduce weight safely in the population and in our patients. The GLP-1 receptor agonists now potentially give us the opportunity to test the idea that lowering weight in the preclinical phase might alter the trajectory, not just to diabetes, but also to some of its complications. So I'm going to end by saying that we're in a new era for cardiovascular management in diabetes. Diabetologists and cardiologists can no longer work in silos, one dealing with blood sugar and one dealing with the cardiovascular complications. We've got to come together because there's a real opportunity to improve the outcomes of millions of diabetic patients using some of these novel therapeutic strategies. There is an even bigger imperative, though, I would argue, to intervene early in the population to slow or prevent the pathway that leads to diabetes. And the idea that we must move upstream in terms of our efforts to alter people's behavior, alter people's lifestyles, and potentially use some novel drugs to alter that is going to be very important. If we're able to do that, we may see collateral gains, not just on diabetes development, but on a broad range of diseases that are part of the unhealthy aging paradigm. So I think by paying attention to all of these cardiovascular risk factors, we are indeed tackling the question that Peter asked us to tackle, the idea that what we really want to achieve is healthy aging. Thank you very much for your attention.